The need for investigations. Very often we talk about hyperfluorescence, hypofluorescence, and so many other things. But what's important to understand is if you understand the pathology that's happening, then everything else becomes easier and what to expect in what condition. So it's important for you to understand the anatomical pathology of that particular condition. Then it's very easy to understand what it will look like in OCT or what it will look like in fluorescein angiography. So coming to my talk on X-files, you've been hearing a lot of basics. We were thinking we'll put some interesting cases that you may or may not have seen. So the first part I'll be doing, and the second half my colleague Dr. Parag will be showing some of the interesting cases in pediatric retina. This is a case of a 42-year-old female who's a police officer, came with a sudden diminution of vision of 4 days duration, mild vision about 6/12 with no other significant history. The anti-segment was normal. When we looked at the right eye fundus, this is the picture, the glistening membrane that you're seeing. What do you think this could be? What would your first thought will be on this when you see a membrane like this? Anybody? ERM, the first thing that comes to mind is an epiretinal membrane. Anything else? The other eye was absolutely normal. This is the OCT picture that shows multiple folds or membrane over the, and then there was some serous elevation. This at different sections the elevation was quite high, and in fact with time, when the patient came in February versus in June, there was a lot of intraretinal edema that had set in these patients. So this is a case of what you might not have heard. It's a familial Muller cell sheen dystrophy, or we call it simply as ILM dystrophy. It's an autosomal dominant macular disorder, not a very debilitating disease. The vision doesn't drop much, but during the course of the time, the patient may have reduced vision in these patients. The treatment is yet unknown. Still, people are trying different, including vitrectomy has been tried with no success. So what exactly happens is there is a defect in the Muller cells. When Muller cell defect is there, what do you expect in ERG? What wave of it gets affected? The B wave gets affected. So what happens is there is a lighter there is a thin membrane that's forming on the ILM, which is produced normally by the Muller cells. Because the Muller cells are defective, you get this defective membrane, and that's how it progresses to form schisis. So that's one. The second case that I'm going to talk about is a new entity which you might be hearing more often. This is a 52-year-old female who presented with a defective vision of 6 months duration. The right eye, had the other eye she had already lost in childhood, so she's one-eyed. Presented with a visual acuity of 6/18, and the other eye was PL negative. And when you see this patient, what do you see here? There is a serous macular detachment. So immediately everybody would jump in and say it's a case of central. What is it? When you say there is a serous detachment, what would your diagnosis be? So is there any other abnormality that you're seeing in this case? There is something here. There's a subretinal hemorrhage. How often do you see a subretinal hemorrhage in a case of central serous retinopathy? Right? So when this patient was subjected to an OCT, Dr. Babu just now beautifully showed some nice slides on OCT. Can somebody describe this? Come on. What do you see? There are two things, basic things that are there. One is pardon? Foveal contour is altered. Is it? But more important than that, what is the specific thing that's happening? There's a pigmentary epithelial detachment with subretinal fluid is there, and there is a fibrinous material here. So what do you think this case will be? PCV. So we did a fluorescein angiogram and see what you're seeing. You're seeing a smoke. Just now he described these. So what will the diagnosis be now? Central serous retinopathy. And what is important here is to see that the choroidal thickness is large, 406 microns. So this patient was subjected to ICG, and now you see a different pathology here. What is this? It's a PCV. So you are seeing a central serous retinopathy and a PCV in this patient. This is another case, again a 70-year-old male, one-eyed. He had a breakthrough hemorrhage in the right eye and had very poor vision in the other eye. The left eye was 612. This is the left eye, presenting with again multiple PEDs and serous detachment, fibrinous exudate suggestive of PCV. Fluorescein angiogram shows what is the hyperfluorescence here. What is this leak called? Ink blot leak. So it means there is a serous CSR. Again with a thickened choroid, you would see, and an ICG showing a hyperfluorescence suggestive of a PCV. So these cases represent three distinct entities, what you will be hearing more often as pachychoroid diseases. Pachychoroid pigment epitheliopathy, central serous chorioretinopathy, and polypoid choroidal vasculopathy are those which will exist in a single, can exist as a spectrum of the disease. So the term pachychoroid is actually used to describe the abnormal and permanent increase in the choroidal thickness with increased thickness of the choroidal vessels, which we call as pachyvessels, and there is thinning of the choriocapillaries and the satellar vessels overlying this. So the pachychoroid pigment epitheliopathy, usually you have this is very often seen in a patient who has got a central serous retinopathy in one eye. If you look for it, you may see this changes, such as the increased choroidal thickness, dilated choroidal vessels, choroidal hypopermeability, and the other eye could have CSR. Well, this eye will have no serous detachment. Of course, you know the central serous retinopathy, how it exists, and the pachychoroid neovasculopathy and pachychoroid choroidal vasculopathy. So this is an entity that you all have to remember is a new term that is being described, such as what is called as pachychoroid. Nowadays, without OCT, this would not have come in, because with OCT you are able to see the thickness of the choroid, actually measure it, and then you are able to say that the pathology that is existing in these conditions. So that's about that pachychoroid. This is another child who had a loss of vision in one eye with sudden loss of vision. She came with a hypopion in the eye, and then with severe congestion. The fundus showed a mass in the vitreous with seedling in the vitreous and an exudative detachment. Can somebody give me a diagnosis? Retinoblastoma. Good. So is this retinoblastoma? So this patient had as I showed you, the hypopion, a mass and vitreous seeding, typical of a retinoblastoma, but this was a surprise. When we did the ultrasound, what do you notice? Do you see something different? What is this? Somebody, quick. Choroidal detachment. Choroidal detachment. How do you say choroidal detachment? What is this? Cysticercosis. This is an ocular cysticercosis, surprising. So this actually had a breakthrough from the subretinal space and ruptured. Since it's a ruptured, so it's presented like an endophthalmitis picture. So we have to do a vitrectomy. This is another case where the cyst is just, you can see the subretinal cyst intact. If it ruptures, then it can cause a picture of severe inflammation, and you need to treat these patients. Next case, a patient who was admitted for dengue was treated with intravenous antibiotics, discharged on the 7th day, but he had defective vision for 5 days in one eye, which was acute and progressive. He had granulomatous KPs, fibrinous exudate, posterior synechiae he had, and then the fundus was of no view. What would you think of the diagnosis as? This was just to give you the blood investigation. He was dengue serology positive. So what could be the diagnosis in this case? We did a B scan. B scan, what would you expect? What do you see here? What is this? What is the lesion that you see here? Can somebody describe? You have all seen ultrasounds. Dislocated lens? What is it? What could it be? Pardon? Organized vitreous hemorrhage, like a, you don't never seen an organized vitreous hemorrhage like a lump like this. So with a mass-like lesion like this, immediately you would think of probably a masquerade syndrome, tubercular granuloma. Our first thought would be a dengue-related ocular inflammation because the patient has come out of just dengue, masquerade syndrome, and endogenous endophthalmitis. It is, the first suspicion is endophthalmitis because, endogenous endophthalmitis, because this patient has been treated with IV line infection, and in fact that was correct, because normally dengue related you would have macular hemorrhages like here, or vasculitis with venous sheathing, or the OCT may show neurosensory retinal detachment. You don't see an endophthalmitis like picture what we have. So this actually turned out to be a fungal endogenous endophthalmitis after we did the vitrectomy and all this. This is a fungal granuloma that was seen intraoperatively. Now this is a very interesting case. I would want you to watch this very carefully, the video. Look at the disc. What do you see here? And then I want somebody you to describe this after this is done. Can somebody say what this is? This is just for the interest I'm putting it. This is not something that you would see very commonly. Can somebody describe what you saw? Pardon? RBCs? No, sir. Disc was what? Disc was eating away something? Like the jaws opening, yes? Ashwin, what is it? Morning glory anomaly with contraction of the disc. Yeah, that was a beautiful picture of video of the disc contracting. It's a rare phenomenon, but it has been reported so many times. It's probably, we don't know exactly what is the pathology. They say there could be a heterotopic smooth muscle in the posterior sclera, which actually works in relation to your breathing. I don't know what the actual connection would be, but there are several theories why this contraction happens, and very often it is provoked by the strong light stimulation and accommodation effect. You see this. So it was a little difficult to capture the video, but somehow we were able to do it. This is another last case of mine where a 25-year-old male who came with a complaint of defective vision in the right eye. The right eye showed a lesion like exudates here and a membrane here, and then when we did fluorescein angiography, turned out to be an adult onset Coats disease with telangiectasia. But what important was, like when we did the OCT of the other eye, you see there were two foveas in this. Then we go back to the picture, you look at this. sometimes we miss it. So this is something can happen. This is just to show you again the video red-free picture, which shows this. But when we did a fluorescein, there was nothing like a foveal avascular zone or any of that in this area. So it has got a striking anatomical resemblance to the fovea, but it's vestigial pseudo-duplication. It is not related to Coates disease. It's just another case to show you how duplication of the fovea can occur. These are reported duplicated lenses, duplicated eyeball, and of course the duplicated optic disc. Just for the interest, I showed you these cases. Now I hand it over to Dr. Parag, who would be talking about pediatric retina in diseases in this. Thank you.
Yeah, good afternoon.